maybe you have to restart. Close the.
Okay, let's close. Let's leave and start everything again. Okay, I'm going to leave and come back again.
Yeah. Okay. Maybe you have to restart. Close the.
Okay, let's close. Let's leave and start everything again. Okay, I'm going to.
Lagi.
Selamat datang kepada dokter pribadi dan dokter Susan.
Apa?
Ya.
Kenapa Zaki?
Selamat datang dok.
Oh iya, makasih. Selamat datang
Ya.
semuanya juga. Kita menunggu yang lain.
Udah live ini, Susan?
Oh iya, itu live on YouTube.
Ya. Kita tunggu Vladimir.
Can you hear me now? Susan?
Yes, Prof.
Udah live ini, Susan?
Oh iya, itu live on YouTube.
Ya.
Mr. Anikin, you're back. PowerPoint is okay? Yeah, yes, this is great. Perfect.
Can you see it now?
Yes, perfect.
Okay. So in this case, we can start probably.
Not yet. Can you?
Not yet.
I will open the. Yes, it is great. Perfect.
Can you see it now?
Yeah. Jaki,
Ya dokter.
berapa residen yang diharapkan datang?
Yang diharapkan datang seharusnya semuanya dokter, tapi mungkin sekitar 70% dokter yang bisa datang.
Oke. Total residen kita sekarang jumlahnya berapa ya? Ada yang tahu nggak?
65 dokter.
65. Iya.
Susan, punya kamu saya berbicara bahasa Indonesia?
Ya, Anda bisa bicara bahasa Indonesia dengan dokter-dokter saya.
Baik.
Selamat sore, Profesor Anikin. Apa kabar? Please answer.
Okay. I think my Indonesian a little bit rusty now. I need to have more training, you see.
So, Mr. Anikin,
Yes.
studied bahasa Indonesia. No, I'm talking to my residents.
Sure.
So, Mr. Anikin studied bahasa Indonesia with an application called Rosetta Stone. Anybody knows what is Rosetta Stone? What is it actually, Mr. Anikin?
Yeah, Rosetta Stone, it's a language tool, learning language tool, and I will use other language tools as well, mainly visiting Jakarta and talking to Susan, you see.
Baik. Selamat sore, Profesor Anikin. Apa kabar?
Someone greet you? Who is it?
Oke.
Dok, sepertinya ada suara dari YouTube yang tampil masuk ke Zoom, Dok. Karena ada yang membuka YouTube tapi mungkin belum ke mute atau bagaimana begitu, Dok.
Oh, so Mr. Anikin, somebody greet you from the YouTube. We don't know who she is.
Bukan, Dok, maksudnya dari tadi rekaman Zoom yang jadi terlambat begitu masuk ke YouTube ya, Dok. Jadi mungkin
saya
tadi,
itu tadi.
Tadi ada suara waktu kita menyapa Profesor namun baru masuk ke YouTube.
Iya ya, gimana caranya orang gitu? Ntar dulu. Sekarang 44 ya yang ini. 15.58, masih 2 menit lagi. Jadi pertemuan saya dengan Mr. Anikin itu adalah di Bali ketika TCSA 2012. Mr. Anikin sebagai pembicara, saya konsulen unyu-unyu baru. Terus ya itulah makanya kalau kita ikut kongres atau ikut acara ilmiah, jangan jalan-jalan terus. Dan jangan duduk paling belakang, terus nggak tanya, nggak apa, gitu ya. Nggak akan ada yang kenal kalian. Kalau kalian ingin dikenal, ya kalian berdiri, ngomong, tanya, memperkenalkan diri, menyapa. Karena itu dampaknya itu bisa besar, networking. Nah, sehingga akhirnya kenal di situ, dan Mr. Anikin memberi tahu caranya supaya saya bisa fellow di tempat beliau. Jadi 2013 saya ke sana, nggak lama sih, 1 bulan aja cukup, ke Harefield Hospital, London. Harefield ini tempatnya sekitar, ini kita sambil nunggu waktu ya. Harefield ini tempatnya itu di pinggiran London. Jadi yang saya bayangkan Central London, ternyata ini desanya. Jadi begitu sampai sana nangislah karena nggak ada siapa-siapa, padang ilalang, banyak fox, banyak rubah, banyak burung gagak, indah, menarik, tapi ya agak serem gitu. Tapi itu adalah pusat kardiotorasik terbesar di UK, pusat transplant terbesar juga, ratusan transplantasi setiap tahunnya. Ya. Mr. Anikin mengerjakan setiap hari banyak operasi toraks, bisa 2, bisa 4, dan dalam setiap minggunya melakukan multidisciplinary team meeting, chest meeting gitu ya, konferensi kasus di beberapa distrik hospital. Itu dilakukan rutin setiap minggu. Jadi ke sana, ke sini gitu. Karena beliau adalah konsultan thoracic surgeon di pusat rujukan. Jadi di distrik-distrik hospital belum tentu ada bedah toraks sama seperti di sini, tapi melakukan konferensi kasus, mana yang perlu dirujuk, mana yang bisa diselesaikan di situ, dan itu terorganisir bagus. Nah, kemudian persahabatannya berlanjut terus. Mr. Anikin hampir setiap tahun datang ke Jakarta. Kalau kita ada PIT atau acara ilmiah lainnya, pernah pelatihan PAS juga datang. Nah, ini saya pikir kita undang beliau ke IBMA, belum pernah kan ya, jadi ini baru terpikir kali ini malah setelah bertahun-tahun. Udah, oke, 51 join-nya, dan sekarang udah 16 lewat 1 menit. Halo Mr. Anikin.
Okay, Susan, thank you for inviting me. It was a little bit quick invitation, so I decided to use my presentation, which I prepared in September for a big joint conference for the whole Latin America, for Colombia, Peru, and Chile and Argentina. So this presentation is slightly biased because it's based on the using specific equipment, but I can tell you that you can use any other equipment, and I'm going to talk about mainly principles of sternal reconstruction today. So can you hear me well?
Yes, yes, very well.
Okay. So before I start talking, I want to say that I have no personal gain in this from this presentation, apart from pleasure talking to you and being in my beloved Jakarta virtually. And this talk will represent only my personal opinion and reflects only what I think about this problem. When I was preparing this talk, I looked into a PubMed and just put a simple keywords into a search, sternal reconstruction, and I found that around 2,000 quotations pop up on the screen. If you look on this graph, you will see that it was progressively, the number of publications was progressively increasing in the first 20 years of the century, but suddenly it dropped now, so maybe some loss of interest, maybe people don't reconstruct sternum anymore, but I don't think this is the case. What's the indication for reconstruction of the sternum? It's various defects, obviously. It could be resection of the tumor when we need to reconstruct it after that, congenital deformity, results of trauma, and what I'm going to talk the most, because it frequently happens and underestimated, and then also it's very difficult area of surgery, is complications of surgery, various operations which was done on our patients. At the moment, in our hands, we have a lot of techniques and methods and materials to use for sternal reconstruction. It could be extremely simple things, like for example here, simple wires and putting a titanium mesh, or it could be very complex individually made titanium transplant to replace the sternum and pieces of ribs. Also, we can use even plastic mesh, various bars, cement, cadaveric bone, you name it, anything basically can be used. The most progressive way to find something to replace the sternum ideally probably is a modern 3D printer using modern materials which would allow replacement of these materials eventually with the ingrowing bone, but it's in the process of development. Over the year working in surgery, I found that surgical tools, surgical techniques, surgical methods will not stay if it does not match three simple things. It should be simple, it should be effective, and obviously it should be available. I'm talking about this specific system for sternal reconstruction called MedExpert. It's a various bars, but as you can see later on, other bars could be used probably with the same effect, and it's up to you, up to a surgeon to modify a technique because of availability of the bars. Before we start the reconstruction, first of all, we need to think whether we need to do it at all, whether it's necessary, because general principle of surgery is trying to avoid complications, and majority of complications in any surgery, whatever you say, in any area of surgery, would be restoration, repair. When we remove something, it's usually okay, but when we try to repair something, usually when problems are starting. So if it's inevitable, we have to think about the functional loss, what kind of cosmesis we can give to our patient, how can we control disease, and can we actually do it in your hospital with your current settings, with your current resources, current technology, and your experience. very often you need to think about very simple way to reconstruct the sternum and try to avoid at maximum any possible intervention or implantation of foreign material. Like it's in a very complex case of a 22-year boy after double lung transplant who suffered for many months with non-healing wound. You can see it here, 6 months of vacuum dressing. And then we managed to close it with a approximation of muscle flaps and a mental transfer with good results, which is holding more than a year already. When you start thinking about planning surgery, first of all, you need to follow the main principle of medicine, primum non nocere. First of all, do no harm to your patient. And then how we can make the repair stable, because majority of problems related to unstable sternum, and what materials can we use and how to minimize the complications. Obviously, before reconstructing sternum, very often we need to remove something, remove the disease from this and do something else. And it should be obviously compatible with life. And if it's a tumor, margin should be clear. And we need to create conditions for reconstruction, removing the tumor. That's for a typical example of very complex chest wall reconstruction after resecting a tumor, when a cadaveric bone was used and implanted in the chest, and you see it fixed with a complex DePuy system with bars and screws, with an intention that this bone eventually will get absorbed and disappear and will be replaced with a normal native bone of the patient. This technique is probably the most common which can be used. It was given by a good friend of mine from Strasbourg. When the sternal sarcoma is removed, very old slide, it could be replaced, the big defect could be replaced with mesh and cement. You see it looks like a shell of a crab here, but it's not the crab, it's a shell. It's a cement with a prolin mesh. And the chest wall is stabilized with bars attached to the ribs to maintain the rigidity of the anterior chest wall. One of the common problems in our patients would be various congenital deformities of the chest. For example, this is also an old slide of mine when I was operating in Libya. This young boy had several attempts by local doctors to remove, to replace, to improve this indentation, because it's quite awful. You see marks on his skin from some homemade devices, but it didn't work. This is more typical pectus excavatum of the patient, and here is the principles how pectus excavatum should be repaired. Usually you see these lines when the cartilages are resected and then can be either removed or reimplanted again, being refashioned, and sternum should be cut somewhere here and supported on the bars. It could be also used for pectus carinatum, which is also could be quite disturbing deformity of the patient. But it's all functional deformities. It's all cosmetic surgery, because patients with pectus excavatum or pectus carinatum, they don't really suffer functionally from that. It's only disturbing view there because they're young people, they don't want it. Have on their chest, that's why they want the surgery. So for pectus carinatum, after repair of the sternum, the bars should be positioned usually in front of the sternum to be supported on a stitches, and that's how it looks after the procedure. Now I'm going to talk to you about a situation which is a little bit rare, and you may see this in your practice occasionally, when surgery doesn't really go well. So when correction is suboptimal and people may have a various retained body in their chest, like in this patient who had an attempt of pectus excavatum repair with an implantation of homemade which became very painful. And also several attempts were made to remove the steel bar, which also put under the sternum, but it wasn't possible. And had 5 attempts to remove this bar, which didn't work. And in this situation, we have to use a special approach. And usually it's a full redo surgery using the incision which was employed before, because ideally it should be transverse incision, but the surgeon here used a vertical incision. So that silicone bar was removed and the sternum was completely refashioned and supported on a bar as well with good results. But usually all foreign bodies which were placed there should be removed, should go, but not always. Like in this situation, when a young girl with double breast implants and pectus excavatum deformity also had this old-fashioned steel bar, which could be removed only with a hammer, with a lot of difficulties. She had her chest repaired and sternum repaired. You can see sternal wires here after transverse the sternum to support it. And the main problem was not to damage previously implanted breast prostheses. Now I'm going to the situation when you probably will see more and more in your practice in Indonesia with your huge problems with traffic and a lot of car collisions. It's a fractured sternum, but it's a different topic to talk about. Usually it's a rib fracture, it needs to be fixed. You can see it here. But we are talking about the sternum today. So this patient had not only rib fractures which were fixed with these bars, but he also developed very unpleasant sensation of clicking and problem in the area of the disruption between the cartilage of the left second rib. You can see this thin line here where the sternum was broken together with a costosternal junction. The problem with this patient was that we couldn't see any damage on all images we've done before. It wasn't visible on CT scan, it wasn't visible on MRI, and it was could be detected only clinically. And we use this specific new type of construction bars on the sternum to secure it, and just in case I put also a circle wire, sternal wire here. And because it was already a third procedure, we decided also to use as an addition these bars, which could probably remove in the future. Now I'm going to talk about the problem which you may see after cardiac surgery. It may not be frequent in Indonesia because a specific type of patients who are usually very strong and usually obese. They have diabetes, and it usually happens after 3-6 months after sternotomy. It can happen at any age. But I believe that because of a sheer number of procedures, cardiac procedures, which are being done in Indonesia, eventually you will come across with this patient and you may ask yourself how you can help them, because their symptoms are awful. They may have previous intervention which do not work, and sternum is usually destroyed. They have comorbidities and very unpleasant symptoms like pain. They can't roll in bed. It's clicking, and they're deeply incapacitated. That's an extreme example of such a situation when the patient had a previous lobectomy for lung cancer and then coronary artery bypass grafting with 3 grafts done by one of my colleagues, my former registrar. And then sternum fell apart. You can see the wires going through the bone. And he attempted to put this construction on the bone itself, which look good, but because bone was osteoporotic, it fell apart completely. And that's a reconstruction after the procedure. You see, it's not holding. And when we started to operate on this patient, you can see the big hole here somewhere and the construction here under the skin. We will come back to these pictures later on. So these patients, as I said, have very significant pain and positional discomfort. They can't breathe. It's a visible deformity here. And when a sternum is exposed, usually it's a big gap you can see here with pieces of wire lying inside and some fibrotic connections there which doesn't work because the parts of sternum are still moving. In this situation, we need to first of all to think about stabilizing the sternum and again remove the foreign body. And we should not attempt to approximate the sternum because it will not work because of usual osteoporosis, and sternum in itself doesn't really exist already. So we have to stimulate regeneration of the bone, feeding the sternal gap somehow and improve blood supply. So the main steps to expose the defect, mobilize the flaps, and then do something to the sternum to stabilize it, usually with bars, and fill the defect with bone grafts. And I'm using Amentum to bring fresh blood supply for the sternum in these patients. So it's how it looks. So the bone is cut with a saw and pieces of bone just flicked inside the gap. Also, we take pieces of bone from the ribs and implant it here. And we use, it's just a Surgicel absorbable material, not to control the bleeding, but to keep grafts in place. And bars are secured across. If you don't have available Stratus bars in Indonesia, you can speak to your orthopedic colleagues and discuss what kind of bars they can suggest, because it's a plenty of material at the moment. Effectively, any bars could be used across fixed to the sternum. But I'm just using the bars here in this situation because it's I'm accustomed to it. So if we continue to talk about this problem, if a patient had a transverse sternotomy here, like a clamshell incision for transplant, and it fell apart, occasionally it's possible to put bars across to secure it to the ribs. Or you can see it here. You see these fine stitches here, which is used to keep all these bone grafts in place, filling the gap. So that's the area of the gap, which is quite big. Then after Amentum is harvested, I usually make a window under the diaphragm here, avoiding putting a flap through the abdomen because it will lead to hernia. And the Amentum is placed over the repair and secured on the perimeter, along the perimeter with absorbable stitches. That's a scan, the slide, and at the end of the operation of the lady I've just shown you in the beginning when we had to remove previously positioned bars. So bars are in place and the Amentum is split in two bits. One is positioned under the bars, making sure they're not compressing feeding vessels, and the rest of the Amentum will be put over it and positioned across the whole, above the whole repair. So that's how this picture looks. It's one of my operating nurses. He's very good in drawing. He made this absolutely brilliant pictures. You can see the scheme of the surgery. That's a defect of the sternum. There's this bone grafts here, brought from ribs and also from edges of the sternum. Harvested Amentum and brought across and fixed on the repair side. Very often you can ask, if you use the bars to fix to the ribs, how we can avoid neuralgia because intercostal, subcostal nerve could be compressed. But it's multifocal, and we never see usually the problems with pain related to these problems. Obviously, this patient needs to be under follow-up, and we need to think whether bars needs to be removed, but bars needs to be removed only if they're causing problems. Usually, ideally, they should stay forever with this patient. They're not without problems, because you see the bar can be broken here, or it can be disconnected. It's a typical technical problems. It happened with one of my patients, but fracture of the bars now more or less prevented, because the new technology allows to use partially rotationable bars when there's some degree of freedom here, so there is no metal fatigue here, and the fracture of the bar could be prevented. So we need to think about removing bars if patients have pain, if the destruction of the bar, and obviously if your CT scan shows repair of the defect and formation of a new bone. So whatever you do with the sternum when you have to operate on it, you have to think about all modern technology available in your hands and think about what you want to achieve. And you have to use everything you have in your hands to use it on your patient. And I suggest also liberally use a mentoplasty and bone grafting, and think about removal of reconstruction if it's necessary. I think that's it, and thank you very much. I am happy to answer your questions.
Thank you very much, Mr. Anikin. Nice presentations. And to the residents, anyone would ask questions to Mr. Anikin?
Izin dok, Afla dok.
Yeah. Please.
Thank you for.
Mr. Anikin, excuse me, could you please stop the share screen?
Okay.
Excuse me, sir. I want to ask a question. Is there any cases of graft rejection that you come across when using cadaveric bone graft for reconstruction?
Can you repeat? I didn't hear you well. Can you say it again?
Louder, please.
Is there any cases of graft rejection that you come across when using cadaveric bone graft in chest reconstruction?
We have very few experience, but I have only several cases with cadaveric grafts, but we didn't see it. We didn't see that, but it's very difficult to obtain this graft even here, because I stopped using it. I'm managing to use natural grafts from the patient, because you can see also take grafts from the iliac bone and use artificial materials. But this is the main problem, but I didn't see this complication.
Thank you, Prof.
Any other questions?
Gary?
Yes, Gary, please.
Hello, Prof. Anikin. Maybe about the sternal dehiscence that we used to construction operation. We don't have any, especially I don't have any experience about the reconstruction about the sternal. But we have quite a few of sternal dehiscence after cardiac surgery. So I want to ask a question about the first one is about the technique of sternal wiring, because in here we close the sternum with sternal wire. Do you have any preference or any knowledge about the technique of sternal wiring? Is it have to be
our cardiac surgeons and myself when I have to use sternotomy, because I am a thoracic surgeon, I don't do cardiac surgery. They use what's called so-called butterfly technique, if you know what I mean. Yeah, it seems to be like the most acceptable, most widely acceptable technique of closure of the sternum in our institution by cardiac surgeon. Also, Susan, do we have time? Because I have about 3 minutes video. Maybe I should show you the video. Yeah.
We have plenty of time for you.
So I'll show you share screen again.
It's not showing. It's not showing.
For some reason, it doesn't work, Susan. I can't place on share screen. It doesn't work.
Zaki,
Maybe I should close this.
Mr. Anikin allowed to share screen?
Yes, Doctor. It's already allowed.
Okay. I probably need to open a file here.
We will wait. We will wait.
Okay, can I ask you later? Okay, just
No time. No problem.
Susan, it doesn't respond. They implies pressing on a share screen and it doesn't work. Should I log off completely and log in again?
Yeah. Like
okay, let's do that.
Yes. Sementara kita menunggu Mr. Anikin, silakan yang masih mau bertanya ya, mumpung ada narasumbernya. Ada yang pernah ikut operasi rekonstruksi sternum di sini? Di mana? Di harapan kita, di RSCM. Kalau di harapan kita, untuk yang dehiscence, pakai apa ya sekarang ini? Repair-nya? Yang udah pernah ikut? Yang udah chief?
Izin Mbak, mungkin pakai Rubis check Mbak.
Masih pakai Rubis check?
Iya.
Belum pernah ada yang pakai bar gitu kayak tadi gitu belum ya? Dan biasanya masalahnya selesai pakai Rubis check aja udah bagus.
Enggak mesti sih Mbak. Kadang masih
Welcome back Mr. Anikin.
Yeah. Can you see anything?
Yes, it's showing.
Okay.
You just need to start the video.
Okay. So you see, that's a typical view of a sternum. You see when this patient was operated twice before that in acute period, had an approximation of pectoral muscle, but sternum was still not working. So you see muscles are retracted laterally, and I use this saw to cut along the sternum, edges of the defect, and then trying to fix bars in place. But as I said, you can speak to your orthopedic guys and maybe represent as a reps and use any other bars which could be put across. The main principle is not to use fixation to the sternum because sternum doesn't exist. This bars has to be fixed to the ribs. And we are fitting bars to the clips. And then using PDS stitch, I'm approximating edges of the bone which we retracted inside, trying to fill the gap. And then we also put pieces of bone there and secured it with a suture cell, and suture cell is also secured in place with absorbable material here, but mainly to keep all pieces of bone there. Answering your question about acute sternal dehiscence, I think this technology should be used more widely, and if patients really have osteoporosis and have an acute sternal dehiscence immediately after cardiac surgery, this technology could be used as well. Because all these patients I'm talking about, they have the sternal dehiscence several months after cardiac procedure. So this is laparotomy and opening the peritoneum.
So it's connected between the laparotomy wound and
yes, it could be connected with laparotomy, or laparotomy could be separate. Separate probably would be better because it would be easier to prevent hernias.
So this is the omentum preparation?
Yes, it's a preparation of the omentum. It's based on the right gastroepiploic artery and the time of the branches. You can use power tool instruments like harmonic scalpel or ligature to divide it, but I prefer old-fashioned technique with clamping and tying. Yeah. And then the window is created, you see here in front of the heart, and omentum placed over the sternum. Because patient already had previous surgery, you have to mobilize again pectoral muscles here to approximate them.
So omentum itself is not enough. You still use some filling other than omentum to fill the gap.
Yes, Susan, I use bones because I cut the sternum and tilt the edges of the sternum inside. Plus I use a bone nibbler to take pieces, small pieces of rib, the size of a match, head of a match, and fill the cavity with a bone. If it's really big, it would be possible to take bone graft from the iliac bone as well, but it was not necessary in my cases.
When you need to take the iliac bone for the graft, are you doing it yourself or you consult to the orthopedic surgeons? And
I never used this technique yet because I always manage to find out the way to fill the gap with pieces of ribs, because I also resect the xiphoid process and put it inside as well. It was never necessary, but in principle, I think it would be quite possible. So if you have a case like that, you can call me. I'll come and you will do it. I'll stand behind your back and tell you what you are doing right.
I'd love to. Unfortunately, we still don't have the chance yet.
So any more questions, guys?
You have questions in the chat.
Okay, I'll open it.
Susan,
Ya.
Ingin tanya.
Okay, the question is where to put a mesh below or above the wire in thoracic reconstruction. It doesn't really matter, but usually I prefer to put it over the bars, not inside the chest. The main reason is it's still a risk of infection, and if you have to go back and remove the mesh, it will be much easier to remove the mesh if it's outside the sternum, not if it's fixed inside the thoracic cavity. Seroma and infection. It's a very important consideration because we had only one serious complication of the surgery when vacuum drains were removed too early and the patient developed seroma with disruption of the wound, and he spent 6 months in hospital with a vacuum pump after that. So the main thing is to put very good drains under the skin and under the flaps. Usually one drain goes under the muscle flaps and another one under the skin. And this drain should stay for quite a while, usually up to 3 weeks or longer. You should never try to remove these drains too early because seroma is persisting, and you just need to wait and sit tight to make sure that everything healed up. So preventing seroma is putting good drains and keep it long. When manubrium is removed, there is no need to connect clavicles because clavicle is quite mobile. It's the main mistake trying to connect somehow clavicles together. In this situation, the best way is to secure the end of the clavicle, maybe to the first strip with a heavy stitch, or do nothing, just to trim the end of the clavicles and leave it there hanging in a soft tissue. And manubrium could be replaced again with any material like cement or mesh as a cement, or 3D printed material made from phosphate and secured with kind of bars to the ribs. So we had kind of flap. What kind of flap do you use after thoracic tumor reconstruction? It could be any flap used. Effectively, if patient didn't have thoracotomy, it could be used. It could be latissimus dorsi flap, particularly if one of your colleagues after breast irradiation can come to you with sternal osteomyelitis. Occasionally, it could be even with a recurrent tumor of the breast. In this situation, that's a huge area of the chest wall should be resected. Ideally, in this situation, you have to reconstruct the chest wall with the bars, put a mesh over the bars, and rotate a flap, latissimus dorsi flap, over there. I don't recommend you to use tram flap because tram flap is based on epigastric artery, which is a continuation of internal thoracic artery. And with sternal problem, very often internal thoracic artery could be either damaged or thrombosed. So it should try to stay away from it. Or preoperatively, you can do just angiography for this vessel and see whether there's good supply going from the internal thoracic artery to the abdominal muscle and use that. So the next question, in sternal osteomyelitis, do you do Robichuk or open repair? I think in this situation, when osteomyelitis develops, it's already quite few weeks or even months or at least days after procedure, after usually major cardiac procedure. So trying to do Robichuk repair is not a good idea because in this situation, you need to go inside the chest. Again, with problems of damaging grafts, damaging heart, and other complications. Because if you operate outside the sternum, outside the chest, not going behind the sternum, usually patients tolerate the surgery much better. So in this case, if sternal osteomyelitis happen, ideally we have to treat the patient removing all foreign materials or foreign bodies with muscles, with vacuum flap, vacuum pump, or if it's a patient is well in general and bone of a good quality, I think it's possible to remove all infected material, remove the bone which is infected. And again, I strongly recommend in this situation to use amentum, because amentum can help with healing significantly. So amentum plus any form of stabilization of the chest. Because all these cases, different cases, and with multiple individual problems and specific features of the patient. So you're welcome to phone me and we can discuss it. If in case of a large tumor, when all sternum is removed, in this case, I suggest use, in your situation, know a little bit about situation in Indonesia. So in your situation, probably acrylate cement together with a mesh is an ideal. So in this situation, when all sternum is removed, the mesh is placed instead of in front of the sternum, in front of the heart, fixed to the ribs. Then you need to pour inside, fill it with cement, wait until it settles, put another mesh usually on top of it, and ideally secure this fixation material with any metal bars which are available. Also, one of your mentors, Dr. Paul from Surabaya, he suggested to use semi-rigid fixation using multiple placement under different angles of sternal wires, but I didn't use this technique myself. So cement with mesh probably an ideal in your situation if you have to remove the whole sternum. No, don't do any pediatrics. So in this situation, probably you just need to follow the general principles, because pediatric surgery is completely different domain. So I never operated on this kind of kids.
Okay. Mr. Anikin?
Yes, I can hear you, yeah.
Could you please start the video? You are not showing in the screen, only your
All
name.
right. Okay.
Yeah.
You can see me now, yeah?
Yeah.
All right.
I need to see you. Okay, Mr. Anikin, thank you for the nice presentations. And you have many questions, and you already answered all the questions. And we are all happy to see you here. I hope
when?
After the pandemic. Yeah, we hope that this pandemic will go away soon, and we will be waiting for you here in Jakarta, Mr. Anikin. Once again, thank you very much for the lectures.
Okay, not at all. I'm very happy to talk to you again, Susan. All the best.
Thank you.
Okay, bye.
Yeah. We